Hello, everyone. Thank you for joining today's presentation brought to you by the Sudden Arrhythmic Death Syndromes Foundation with support from Invitae, titled Estimating and Managing Risk in Patients with Long QT Syndrome and Catecholaminergic Polymorphic Ventricular Tachycardia. Today's presenter is Dr. Andrea Mazzanti, who is a cardiologist and researcher in the Molecular Cardiology Division of the Maggiore Scientific Clinical Institute at the Scientific Institute for Research in Healthcare in Pavia, Italy. Since 2012, Dr. Mazzanti has worked with Professor Silvia Priori on clinical research in the field of genetic diseases of the heart. Before Dr. Mazzanti begins today, I would like to mention that you can submit questions anytime during the presentation for the Q&A session. Today's webinar will be recorded and available for later viewing on the SADS Foundation and the Invitae websites. Dr. Mazzanti, we thank you for your presentation today and have really been looking forward to it.
Hi everybody, and thank you first of all to Invitae for hosting this meeting, and to Alice Lara for organizing. I think it's really exciting to be here. And I think that we will go through some of the points that are useful to cardiologists to manage patients with long QT syndrome and catecholaminergic polymorphic VT. In case of any question or doubt, I think that you are free to interrupt me, and I know that you are going to submit questions, so I will be more than glad to answer to your doubts if I can, and to share my point of view on your uncertainties. We chose long QT syndrome and catecholaminergic polymorphic VT because I think they are pretty much archetypal disorders. Long QT syndrome has been described over 50 years ago, and over the time it has been recognized as the archetype of inherited arrhythmia syndrome. So many concepts have been understood about the pathophysiology of the disorder and the management of patients, that has been based also on the possibility to implement genetic screening and genetic information, not only to diagnose the patients, but also to risk stratify the patients, as we will see, and also to manage patients. So I think that long QT syndrome is really the disorder that allows us to understand and which can be all the potentials of genetics applied to inherited arrhythmia syndrome. Also due to its strong monogenic connotation that makes it easy to understand also the background in the genetic meaning. And we also decided to go through the catecholaminergic polymorphic VT because instead this is a much rarer disorder. It has been clarified from the genetic standpoint much because we know that the majority of patients have mutations in 1 or 2 genes, that is the ryanodine receptor cansequestrin. But I think that the genetic information is still not completely exploited to help patients. So I think that it will leave open perspectives for the future. And okay, so long QT syndrome and catecholaminergic polymorphic VT actually have many points in common. Here you can see. So one of the most important is that patients with long QT and CPVT experience their arrhythmias, especially during exercise or when in the occasion of emotional stress. And this is pretty common because we know that this may represent a problem, especially in athletes, for instance. The other point which is remarkable is that the fact these disorders may manifest since the early ages of life. Many things that especially long QT syndrome may be one of the causes also of a sudden infant death syndrome. So it is important to recognize since the early ages of life. In catecholaminergic polymorphic VT, probably things are a bit different because we know, as far as we know, that the arrhythmias start in a later stage, around 8 to 10 years of age, but still in young, before adolescence. We also know that despite having differences related to gender, for instance, in phenotype expression of long QT syndrome or specific subsets of long QT syndrome where you can have the gender influence, especially, for instance, after the pregnancy in long QT syndrome to women, we know that overall the gender differences are not major. So I think that patients may benefit of equal treatment in two genders. And also we know that they share the response to beta blockers that are considered the mainstay of treatment. And especially, as we will see with nadolol, the evidences of the superiority of this molecule over the other beta blockers are now widely recognized. So it does not change, yeah. So, but there are also differences that need to be acknowledged in the two disorders. First of all, as we were saying, long QT syndrome is a disorder where we have advanced information to re-stratify patients, also to choose the right treatment, whereas in CPVT, the management is mainly like based on a previous history of major symptoms or probably some information obtained from the family history. However, we also know that many things still need to be understood. And so going to the subject that we were discussing previously, we know that the genetic screening in long QT syndrome, as we see here from this document published by Dr. Ackerman and Prior in 2011, we know that in long QT syndrome, the yield of genetic screening is pretty high. We can now reach a diagnosis in about 75 to 80% of patients. And we know that 90% of these patients have mutations in one of the three main genes associated to the condition, whereas all the other genes associated to long QT syndrome account for about 10% of total cases. And beside having this high yield, we also know that the genetic screening is very useful to confirm a diagnosis in doubtful cases and also to identify silent mutation carriers in families. And we also know that the test is useful for prognosis in patients. We will see some more data in a few moments. And also you see that there is some utility of the genetic information to justify for the therapeutic choice in individual patients. So I think that, I mean, we really need to acknowledge, and I think that no one has doubts nowadays that when we see a patient with long QT syndrome or a suspected long QT syndrome, we really need to consider genetic screening as a part of the management of the patient. It's something that should be routine. And we know that maybe in some countries of the world, it's still a bit difficult to have access to genetic screening, also for cost problems, but I think that an effort should be made to make it easier to access to everybody. And we also know that the genetic screening is able to help us in like managing the patients. We will see in a moment that nowadays it's really possible to have genotype-specific information that help in managing the patient and choosing the right therapy for them. So the first point that we were discussing, as you know, you see here these data that have been published in 2003 by Professor Priori and co-workers. We know that the survival in patients with long QT syndrome is really modified by the genotype. You see here something that we all know, but it's always nice to remember. Patients with long QT type 1, which is like one of the two most frequent forms of disorders, is really one characterized by pretty benign clinical course. We see that the event rate over the course of the first 40 years of life is around 0.3% per year before treatment, and overall, of course. This means that basically many patients with long QT syndrome type 1, even if when they have a phenotype, they don't manifest major arrhythmias. The thing is completely different when we go to see patients with long QT type 2, that is the second most frequent form associated to loss of function mutations in a potassium channel, and in the long QT type 3, which is associated to a gain of function in the late sodium current. And these two forms have a worse outcome, you can see, and the event rate is double as a respect to the type 1. So apologies, just a moment. Okay. And here you see the other determinant of the risk in patients with long QT syndrome is really the severity of the phenotype quantified by the duration of the QTC interval. You see here the same data published in 2003 over 600 patients. we see that when your QTC is like in the first quartile, that means under 440 milliseconds, that is like normal QTC, you see that the event rate is really low. I mean, it's not zero, and it is worth remembering this, because we know that also patients with a mutation that is pathogenic for long QT syndrome, but without QT prolongation, may still experience events. For instance, when they take any drug, some drug that may prolong the QT interval. Not many antibiotics, antihistamines drugs may have this effect. So it's worth remembering that patients who are carriers of a mutation without the phenotype, they have a reduced repolarization reserve that may predispose them in experiencing arrhythmias in special occasions. And we see that the severity of the disorder that increase when you go to upper levels of QT duration. And you see, especially this is another number which is a little magic number to remember: when the QTC is above 500 milliseconds, the risk becomes substantially and significantly higher. These are traditional data that were like based on the first large cohorts of patients followed at our center. We also know that the response to beta blockers therapy, this was published in 2004 on JAMA, is also dependent on the genotype. And we know again that long QT type 1 are the patients who respond better to the therapy with beta blockers, whereas you see again long QT type 2 and long QT type 3 have pretty much an overlapping clinical course with more severe outcome also in terms of response or lack of response to beta blockers, as you see in this survival curve. And you see that as compared to long QT type 1, patients with long QT type 2 have 3 times higher risk of failure of beta blocker therapy. We need also to explain to our patients. And patients with long QT type 3 may have a 4 times higher risk of experiencing a beta blocker failure. Also, we will see this data need further discussion, because probably there are some news on this subject. And finally, here you see, according to the guidelines of the European Society of Cardiology, which are the indication to use the ICD in patients with long QT syndrome, for sure there is a class 1 indication, means that this is recommended, and with pretty high quality of data that support these decisions, that patients who have experienced an aborted cardiac arrest or any kind of life-threatening arrhythmic event, they have an indication to implant the ICD. No matter the genotype, no matter the duration of QT interval, when you don't have a reversible cause for cardiac arrest, such as the drugs that we were discussing earlier, then you need to go to the implant of a defibrillator. Again, you see that there is also a recommendation of class 2A, that means that is maybe considered and should be discussed with patients, that the implant of ICD is considered in patients who experience a syncope when they are receiving an appropriate treatment with beta blockers. And we know that this is a stronger marker of risk. The failure of beta blocker therapy in terms of syncope is really important to remember. I think that we should always keep into consideration. Maybe it's difficult sometimes to decide whether a syncope that occurred during treatment is really arrhythmic ones. But I mean, this is a problem that we face every day. Some strategy to overcome this problem may be the use of a loop recorder that allows you to monitor your patient and to put his or her symptoms in correlation with the underlying heart rhythm. But I mean, I know this is not always available, but we use very often in our patients. I have to tell you, this gives us pretty much satisfactions. And again, the last category where you can consider the implant of a defibrillator according to the guidelines, still based on the 2003 data, is the presence of a QT above 500 milliseconds in patients with a genotype that we have seen are at increased risk of arrhythmias. The kind 2 and the type 3 of a long QT syndrome may be associated to a risk that justify the implant of a defibrillator in primary prevention. And this is pretty much these are pretty much the two causes where you need to consider the implant of a defibrillator in primary prevention, according to the data published in 2003. However, as we see here, there are new data that may need we can consider. And these are data that we published in 2018 on the Journal of the American College of Cardiology, 1,700 patients. Here you see, basically we have one of the first thing to remember is that nowadays, with the wide use of genetic screening, we need to consider that about 50% of the patients with long QT syndrome have actually QT interval and with pathogenic mutations, of course, not variants of unknown significance or non-pathogenic, but also with the variants of likely pathogenic or pathogenic strength. We have about 50 or 60% of patients who do not exhibit any QT prolongation on their electrocardiogram. This is something that is worth remembering. But what is important is that due to the availability of large sets of patients and according to the different genotype, we were able to define a risk. According to the 3 genotypes, as we have seen previously, we maintained the same scheme, but now we were able to obtain a risk stratification based on 10 milliseconds increments, you see here. So basically, this allows us to answer a question that is not easy to answer if you think about the recommendation here on the guidelines, because before we knew when you are above 500 milliseconds, especially if you have more than 500 milliseconds and you have a long QT type 2 and type 3 with more than 500 milliseconds of QTc interval, you may be at sufficient risk to justify the implant of a defibrillator. Now we are also able to discriminate these patients like more and to have like event rates that are differentiated according to the different groups of QTc interval duration. And here, yes, you see that, for instance, it's possible to define which is the risk in a patient with long QT type 2 and a QTc between 500 and 510. This is like 5% at 5 years. So this is, but if you go to look long QT type 3, then you see that the risk is like 1 point higher. It's about 6%. And again, if you go up with the duration of your QTc interval, for instance, you are like, I don't know, above 530 milliseconds, then what you see is that the risk may reach 7 or 8%. So these allow you to recognize cluster of patients where the risk is really much higher. And I want to show you something that I hid before, but I want to show you. Here, these are the same categories of risk, but the group divided by larger groups. You see that especially we like to use and show this chart to our patients to show them the risk before antiarrhythmic treatment with beta blockers, to also explain why in some categories of patients, especially the orange and red that you see here at the right bottom corner of your screen, these are patients where you may really need to consider the use of a defibrillator also in primary prevention. So basically what we got was a more defined way to risk stratify patients. Okay, so another aspect that is really important to consider is the possibility to have a genotype specific treatment for your patient. And in this regard, we need to remember the data that have been published, I think, in 1996 by, again, the group of Professor Priori. Here you see the slide. So it was already demonstrated in 1996 that producing, here you see the possibility to obtain a pharmacological model of long QT syndrome type 2 and type 3 that you may induce in Guinea pigs administering antopleurin and dofetilide. Antopleurin is like a sodium channel blocker that mimics the long QT syndrome type 2. Dofetilide is an IKR blocker that mimics long QT syndrome type. Sorry, antopleurin is a mimicry of long QT syndrome type 3, and the dofetilide is a mimicry of long QT syndrome type 2. Basically, what you see is that in the cells of these guinea pigs administering these drugs, you prolong the duration of QT interval, and when you administer a sodium channel blocker like mexiletine that is effective in blocking the late sodium current that is disproportionately activated in long QT syndrome type 3, basically you are able to shorten again the duration of action potential to pretty normal values, whereas this effect is not reached apparently in long QT syndrome type 3. we have seen data that have been published recently where it is supposed that mexiletine may also work in long QT syndrome type 2, but these are preliminary data, I think. What is really acknowledged here, and you see our data published in 2016, where we have a cohort about 35 patients with long QT syndrome type 3 that you see represented here on the left part of your screen, and the majority of patients had QTC values above 500 milliseconds. Some of them were very high duration of QT interval. You see that the red line is the lines that shows you the QT, the 500 milliseconds, that is the threshold we were discussing previously. And the blue line is the 460 milliseconds that represents the normality of QTC interval. You see that before treatment with mexiletine, over 90% of patients, or maybe 80% of patients, had QTC above 500 milliseconds, whereas after the administration of mexiletine, the QTC goes below 500 milliseconds in the majority of cases. And in the most cases, patients also have a completely normal duration of the QT interval. That means the drug is really effective. And as you can see here that the effect is pretty consistent, because the average shortening was in the range of 60 to 65 milliseconds with a very small standard deviation. That means the effect is pretty much homogeneous. And you see that as you see here, the number of those with the QTC above 500 milliseconds goes down to 18%, starting from about 65 to 70%, and the majority of patients have a QTC normal after the mexiletine. This was really important to confirm the data that were obtained about 20 years ago. We were also able, for the first time, to also demonstrate that the rate of life-threatening arrhythmic events occurring during match periods of times before and after the treatment with mexiletine was dramatically reduced in patients with long QT syndrome type 3 when they received treatment with mexiletine, you see here. And also we know to remember that as for any drug, not all patients will respond. You know that, for instance, also in the use of quinidine for short QT syndrome, or the quinidine for Brugada syndrome, or mexiletine for long QT syndrome type 3, you will never have 100% responders. It is unrealistic to tell your patients that all the cases will be treated. We know that there is also mutation-specific responsiveness to the drugs, like for instance in this case, but in the majority of cases will respond. And those who did not respond were patients with a dramatically high QTC values above 600 milliseconds before. So even if in 2 of the 3 cases you got a pretty nice and impressive reduction of the QTC interval, still it remained long. And this we can take like a little home message from here, that is when after mexiletine treatment your QTC duration remains above 500 milliseconds, then you need to consider that your patient is still at risk, because of course we know the importance of having an arrhythmogenic substrate in these patients, so you may need to consider further treatments, like for instance stelectomy or even the implant of a defibrillator in those patients. Okay. So if we can move further to the CPVT, so we know that, as we were saying, that for sure the role of genetic screening is like different. For sure there is a role in the diagnosis of patients with CPVT, because for a simple reason. We know that, as I was saying, for long QT syndrome, we know that patients with CPVT that carry a pathogenic mutation in the ryanodine receptor may not show always arrhythmias, like the classical bidirectional VT on their exercise stress test Holter. However, as the data by Hayashi in 2005 demonstrated, those patients still remains at risk of experiencing life-threatening arrhythmias, for instance, in the occasion of exceptional stresses. And we also know that there are some mutations in the ryanodine receptor that may be associated to idiopathic ventricular fibrillation without the classical phenotype. Still, they need to be taken into account. So again, the identification of silent mutation carriers in the family is really important, and this is the main reason, besides confirming the clinical diagnosis, why the genetic screening may be useful also in patients with CPVT. On the contrary, the prognostic value of the ryanodine receptor mutations and calsequestrin mutations is still limited. There were reports suggesting as obvious that the homozygous form secondary to calsequestrin mutation may have a more severe clinical course. However, I mean, these are just very preliminary data, and but we know that patients with calsequestrin mutations may have a more severe arrhythmic burden, of course. And also the other point is that as for the choice of therapy, the genetic screening still remains very, I mean, preliminary to indicate patients who may or may not benefit of the treatment. Another important aspect is that the yield of genetic screening is lower in CPVT as compared to long QT syndrome, still remains above 50 or 60%, demonstrating that for sure it is worthwhile screening your probands with the clinical suspect of CPVT. It's important to be a bit stringent of the clinical diagnosis, because if we accept that all patients with very few or isolated ventricular excess systole during an exercise stress test, they have a diagnosis of CPVT, of course the yield of genetic screening will become lower. However, if you are stringent on your clinical diagnosis, then the yield of your genetic screening will increase. And the last thing that I wanted to say about of course the genetic utility for treatment of patients, of course, is that when you consider that you may recognize if a patient has an autosomal dominant or autosomal recessive forms of the disease, may help guiding you in choosing the therapy the day that gene therapy will be available as a treatment for patients with inherited arrhythmias that one day will come. So of course there is a prospective utility, it will be found in this patient too. When we go to risk stratification, we have to acknowledge that it is a pretty, I mean, preliminary in the data, or as compared to long QT syndrome, because we know that there are clinical risk stratifiers that are pretty useful and strong. You need to consider them, especially a history of syncope, again, is very important as a risk predictor, and we need to remember that again, also in this context, having the availability of a loop recorder may guide you in identifying those patients who experience arrhythmias that are not sufficiently long to cause a cardiac arrest, but sufficiently long to cause patients to lose his or her consciousness. And the other important thing is that the younger the patient at diagnosis, the higher the risk of him or her experiencing life-threatening arrhythmias during the observation. We know that this is pretty obvious, because it means that if the heart is able to fibrillate at a younger age when it is still small, means that probably the disease is more aggressive. And of course, patients who, again, will survive to a cardiac arrest have to be considered a very high risk and need to be treated aggressively. Finally, it's not trivial to remember that, again, the therapy with beta blockers, which is the mainstay, I mean, may have failure, especially in patients who do not take it regularly. So we need to stress in our patients the importance of being very precise in taking their drugs. And again, I think data by Ayashi demonstrated or suggested that nadolol, again, may be the most useful treatment for these patients, of course. When we come to genetic, as I told previously, there are not very useful risk stratifiers still. So I mean, it is a bit more complex, and we know that very often the decision how to approach your patient to decide whether beta blockers are enough, if you need to add something like flecainide that we know has been again suggested, not demonstrated to be useful in reducing events in these patients, may be necessary, or even the choice to using a defibrillator in a cohort that has, we know, a very delicate profile on the arrhythmic risk, and where a defibrillator may be useful, but still may have a very high rate of complications, especially associated to inappropriate shocks, may be important to remember. So I think here it's a bit more complex than the classical long QT syndrome. I think that here the only recommendation about the ICD implant in the guidelines of 2016-15 was associated to patients with CPVT who experience a cardiac arrest or who have a recurrent syncope while on beta blockers, or those who experience like long stretches of bidirectional polymorphic VT during exercise despite the presence of a beta blocker at full regimen. Again, we need to remember the nadolol and other beta blockers need to be given at the right dosage to be effective. So when you give nadolol, you need to target the 1 milligram per kilo per day, that you may also divide in 2 doses if you want, but still you need to be like insisting with your patients that it's important to take every day the right dosage of the drug. As I was telling before, there are like possibilities that are emerging for the treatment of CPVT, and I like remembering the sodium channel blockers because there are pretty many evidences in vitro and also in vivo with some initial clinical data that demonstrate the efficacy of flecainide for sure in suppressing the burden of ventricular arrhythmias. Then it still needs to be demonstrated whether suppressing the arrhythmias corresponds to suppressing the rate of life-threatening arrhythmias. But in patients who have symptoms of arrhythmias recurring during beta blocker therapy, it may be useful to consider the use also of flecainide, always in association with the beta blockers, not alone. I think there are some data published on Heart Rhythm with an editorial by Carlo Napolitano where it was demonstrated that the monotherapy of flecainide is not useful alone. We need, of course, more data to confirm. And the other opportunity to use flecainide is also in patients who have a defibrillator, because we know that inappropriate shocks may be really dreadful events in these patients because of the pain and the shock associated to being shocked may like enhance the release of catecholamines, and then this may be really a lethal complication in patients with CPVT. So if you have patients at risk of experiencing inappropriate shocks and you cannot modify the programmation of your defibrillator, you may consider to use a combination of beta blockers and flecainide to reduce also the burden of appropriate shocks and inappropriate shocks as well. And I think that, yeah, the last word is about left cardiac sympathetic denervation. It seems to be useful both in patients with long QT syndrome and in CPVT. There are evidences demonstrating that it is useful to reduce the burden of arrhythmias. Again, as for flecainide and as again for mexiletine in a subset of patients, none of these treatments actually can replace the use of the defibrillator to save the life of your patients, whether they have a substantial risk of experiencing a life-threatening arrhythmia. However, it is worth mentioning because in many parts of the world it is used, and of course it requires that the clinical team performing this kind of intervention is very well prepared. You need to have a nice experience and large sets of patients studied in order to get a complete elimination of the left ganglia without creating too many complications in your patients. But it may be useful. I mean, long-term outcome data are limited. We know that there are some experience from the Mayo Clinic and also some experience from Pavia group, but these are like not confirmed in the very long-term follow-up. Still, they need to be mentioned because they may be worth considering in patients, for instance, those who are intolerant to beta blockers, those who continue to experience shocks despite optimal treatment with beta blockers and flecainide. That honestly would need to be quantified, because I think a good association of beta blockers and flecainide in CPVT pretty much suppress the majority of arrhythmias in the majority of patients. I think that this is the end of my presentation, and I would be very happy to answer your questions. Thank you.
Thank you, Dr. Mazzanti. Just to remind the audience, please submit questions by typing them in, hitting the submit button. The first question comes from Dr. Christoph Slaby about risk stratification models. He asks, there's been a interaction between long QT subtype, sex, and age. And in the last model that you mentioned earlier in your presentation, those predictors are addressed separately. And he asked whether or not is the interaction really gone? And can you please comment on the higher risk in young long QT subtype 1 males and older long QT subtype 2 females?
Oh, yeah. Thank you. This is a really important question. The model that I showed you was not distinguishing between males and females. However, in our multivariable analysis, the gender was still associated with an increased risk, and independently from the genotype, females had a higher risk. So this is something that is known. Then we know that there is also an interaction between age and gender, no? Because the classical data by the group Dr. Moss demonstrated that the males are the higher risk in the very early ages, whereas females start having an increased risk after adolescence. Still, the short answer is that the model I showed you was independent by gender, but still when you have a female, you need to consider a higher risk. Also, the model I showed you was before treatment with beta blockers. So this is important to remember.
Terrific, thank you. In long QT subtype 3 patients, is there any dose response with mexiletine? And what about other drugs like ranolazine?
Okay, so starting from ranolazine, we don't have experience about ranolazine. I know that some has reported. I think that the response to mexiletine actually, honestly, is the higher that we observed. Also in comparison with others drugs that were selective late sodium current inhibitor, we got some experience, and we still found that mexiletine was the most powerful. Honestly, the dose response. I think that the clinical parameter that you need to address is not the dose, but the shortening of the QTC interval. So you have a target. You need to go below 500 milliseconds in your patients, let's say. Or if you want to go back to normality, you need to take 460 as a reference to get below 460. So you can, of course, mexiletine is, I think it's a pretty easy to use, not toxic. There is like pretty much a large, not large, but sufficiently large therapeutic window. And for instance, in our laboratory, we also dose the plasmatic levels when we give to patients, because we are pretty much interested in knowing that the therapeutic range is reached. But actually, what you need to address is the shortening that you obtain in your patient. That is pretty much individualized. So you need to look in your specific patient, which is the effect on the electrocardiogram, more than targeting a certain dosage to administer.
Great, thank you. What is the feature of nadolol that makes it preferred?
Sorry, I didn't get you.
Why is nadolol the preferred beta blocker?
There are many data that, not many data, but there are some interesting data. So basically, first, we demonstrated actually that nadolol was like the most effective in long QT syndrome, and this was confirmed in a multivariable analysis where you got, I think, 70% reduction in the risk as compared to no therapy that was significantly present only for patients with nadolol, and not that, for instance, with the selective beta blockers at all. And also with propranolol, there was an effect, but it was not significant. I think the big problem of propranolol, as you know, probably in your clinical experience, is associated to the fact that it's pretty hard for patients to stick to 3 dosage per day of a drug. It's pretty much easy, people forget, and then you know that events happen when people forget their beta blockers. So I think that the problem of propranolol is associated more to the pattern of receiving the drug. As for the question why nadolol is more effective, I think there was a nice editorial by Andrew Grace to our paper on JACC last year, and basically the concept is that blocking all types of beta receptors is what you really want to address in your patients, because there are mechanisms of compensation. If you block only 1 or 2 of these receptors, then the other subtypes may increase in their activity and being more exposed to the membrane. So therefore, they bypass the block that you are giving just the beta 2 selective as metoprolol, for instance. So this is the reason, in my view.
Great, thank you. Beyond long QT subtype, are there any other phenotype-genotype correlations, for example, established mutations with higher risk than other mutations within the same subtype?
Within the same subtypes, you mean like long QT type 1, 2, and 3?
That's right.
Yeah, I mean, there are many data, for instance, by Dr. Moss in the mid-2000s, where, for instance, was clearly demonstrated that mutations in long QT type 1 or 2 who affect the pore of the channel are associated with an increased risk that was substantial. So, of course, genotype to spread, and all, for instance, in long QT type 1, the A341V mutation is very malignant, so there are genotype to phenotype information that may be exploited more. And of course, you can have a genotype specific risk stratification for your patient. I mean, it's possible for few mutations, and I would approach with caution, because we also know that the phenotype is very variable based on many parameters, but still I think that it may help in risk stratifying your patients, of course.
Great. Is there any potential multi-therapy for long QT subtype 3 patients who are not lowering their QTc below 500 milliseconds?
So multi-drugs means, for instance, mexiletine to combine with something else?
Mm-hmm. Yeah.
Oh, well, yeah, well, it depends. So when patients are not too bradycardic, we also use beta blockers. Of course, they don't shorten the QT, but well, my impression is that we don't get many. I mean, I don't have experience of combining antiarrhythmics in long QT type 3 besides using mexiletine, honestly.
Thank you.
Also because, I mean, for instance, using other class 1 antiarrhythmics, I mean, you don't want to suppress too much the peak current. I mean, you know, there is a pretty strong inotropic negative effect. If you use flecainide, for instance, I wouldn't recommend at all. Honestly, I don't have experience. I would not recommend, like, from the electrophysiological standpoint.
Great, thank you. The mother of a young patient, a male who is diagnosed with sinus bradycardia, numerous PVCs, and a prolonged QT interval, asked whether or not nadolol may help minimize PVCs, shorten QTc without slowing the heart rate.
So if I understood correctly, you were asking whether nadolol may suppress PVC without making the boy too much bradycardic, right?
Yeah, that's right. That's right.
I mean, of course, nadolol is pretty much negative chronotropic. I also think that the bradycardia is a problem, like relative problem. I mean, you need to verify, you need to do a Holter to understand, because bradycardia, of course, may be associated to an increased arrhythmic risk in some kind of long QT syndrome. So genotype would help in that context. However, I think also that bradycardia is not like a problem in a healthy heart from the, I mean, mechanical. If the heart is normal from the mechanical standpoint, it needs to be evaluated carefully. Also because it's pretty uncommon to have PVC or non-sustainability in long QT syndrome. So it would be necessary to understand better the case. I am very happy to review the case, like if you have data to share.
Thank you. What are the long-term side effects of beta blockers? And someone asked, does it really affect fertility in males?
Oh, I mean, this is an interesting question. I think that there are no data about this subject. I mean, of course, it can give like some problem to males, but also we see that the majority of patients do not complain of any side effects. So I mean, there are some data about possible effects on the glycemic control, but they are very like rudimental data. I think beta blockers are used since about 50 years or 40 years, and no very major side effects have been raised, honestly. So I wouldn't be worried too much about this. We don't see very severe outcome problems in the long term.
Great, thank you. The family member whose husband has been diagnosed with CPVT, she's an ICU nurse and has read that epinephrine should not be used in a patient diagnosed with CPVT during cardiac arrest. Could you comment on that?
So you don't use epinephrine when a patient with long QT syndrome has a cardiac arrest?
Patient with CPVT.
Ah, yes, of course you don't. I mean, of course, you don't use anything. I mean, you don't want to enhance the adrenergic tone in a patient with the CPVT. That is why it is probably to have probably something in your wallet or something that says this patient is affected by CPVT. I mean, of course, it depends, because in a clinical emergency, you use whatever you need. And this is like something that the doctor on that moment decide. But I wouldn't recommend using catecholamines in a patients with CPVT and a cardiac arrest. And then, of course, it depends on the clinical context. I mean.
Sure. So I think that concludes. There haven't been any more questions asked in the last couple of minutes. So I think that this concludes the end of our Q&A session, unless another question pops up in the next couple of moments.
Yeah, I'm here. Very happy to.
All right. Well, I think this marks the end of our time together today, Dr. Mazzanti. We really thank you for your presentation and sharing all of your insights with us.
Oh, thank you to you.
Have a good evening in Italy.
Yeah, and a good day for you all around the world.
Thank you very much.
Thank you. You are so kind.